So for now, I'd like to invite Tony Carden and Perdita Dickson up.
Thank you, Sam, and thank you, Ken, for another great presentation. And I've enjoyed your several presentations that I've been present for in the past few days, and they're not, there's overlap. You've managed to hit different angles each time, and each time I come away thinking there's really no gap between our views and our perspectives. I think the same is true of Janet, and it can seem, I think, to people like we're a bit of a cult, these human factors people, systems thinking, and I'm sure you can find on LinkedIn and among management consultants the bandying around of the term systems thinking. So I want to start by unpacking some of the core concepts. I'm going to start with the very basic one, which we probably all assume we know, a system. What is a system? So for me, a system is just more than one thing, so a couple of things or more that interact to produce some kind of outcome. If there's no interaction and there's no outcome, it's not a system, it's a set of things. So Ken's nice pictures of operating theatres up there. The first two, you might think of them as systems, you might even think of them as complex, but in fact they are sets of things. There's no interaction in those boards, in those rooms, until you bring people in. As soon as even one person comes in there, and a person is itself a system, I want to argue, it becomes a complex system, and it actually becomes a system because there can be interaction and there can be outcomes. So human factors, what does it mean? In one of Ken's talks, he talked through the different ways of understanding the phrase human factors, and he's touched now on the lay notion that it might mean human error and all the faults and failings of humans, and when something went wrong it was because of those damn humans, and we can see that all over the place. But when we drill down in depth, we realise that we are actually part of a system, and the systems that we're part of are socio-technical systems. Bit of jargon from the cult there, but that simply means people, technologies and processes interacting. That's all it is. So a system, more than one thing, interacting to produce an output. Socio-technical system, systems that have people, technology and process in them. So far, so good. So how do the interactions happen? What are the interactions? And the way, and Ken mentioned this yesterday, once you start thinking this way, it shapes the way you walk around the world. So I think simply in terms of affordances and constraints, right? So every object in my environment, and this comes from ecological psychology, every object in my environment and the environment itself, I can interact with it and it affords me certain things. So I could sit on that chair, it has the affordance of sitting. I could stand on it, that's another affordance. Something I might call a malaffordance would be falling off it. So falling, sitting, standing are all affordances of my interaction with that object. So affordances. Constraints. There's a bunch of constraints. So, I can't reach the top of the roof. I'm constrained by my height and the height of the room. I'm not going to stand here and swear black and blue at you because of some social constraints. There are legal constraints. There are practical constraints. There are constraints of the capabilities and limitations I have as a human. So to break it down, systems, socio-technical systems, and the interactions that can happen are all about the affordances and constraints that people are faced with by interactions with the people and the things in the system. So that's the baseline from which I want to just talk to you about. It's going to be a bit of a flying tour through some of the ways that we've been applying those insights at WorkSafe in the past few years. But before I get to that, going back to the cult idea, we might think we're trying to convince you to join the cult. I want to suggest to you that you're already in it. I want to suggest to you that all of us are natively and naturally systems thinkers, and it gets beaten out of us. Why does it get beaten out of us? Because we live and work in systems that are not designed that way. We live and work in systems that are linear, reductionistic. Why? Because the Industrial Revolution and the scientific revolution that it was based on broke things down into little parts and pulled them apart to find out how they work, and that led to massive growth and all of our lives getting longer and better and richer and all those sorts of things. So all of our institutions, our healthcare system, our regulators, our government, our whole social setup is based on that linear reductionistic model. And yet if you look at kids playing in a playground or look at earlier cultures, you won't see that reductionism. You'll see holism. You'll see people interacting in a holistic way. But we get acculturated out of it And that's the final bit of terminology I'm going to try and define here. Culture is basically our beliefs and our behaviours and the artefacts in which they're embedded. So if you think of the complex of our socio-technical systems, and when we say technology, I'm not just talking about physical tools, cognitive tools as well, so our thinking tools. So the artefacts that shape our culture are telling us the world is shaped like a hierarchic tree. Even if that goes against the grain and it's not what happens in our work, that's what we're constrained into. So there's the background. Okay, what slide are we on? So that brings us to this harsh sounding bit. Our tool, our primary tool at WorkSafe is the OHS Act. And this clause in it, this subsection talks about a system of work and employers' obligations to provide one that is, so far as reasonably practicable, safe and without risks to health. What does that mean? And so for a long time, there was no description of what a system of work is or was. And in recent times, very recently, we have recognised that as a problem and we are now articulating this. And I want to be clear, this is a description. We're not allowed to call it a definition for legal reasons. But it's a description of what a system of work is. And really pleasingly, in putting this together, we went back through case law, collaborated with our legal people and others to work out what's the best way of describing a system of work and how have judges seen that in the past. And what you see on the screen is the result. And in that, you can see Ken's work as imagined and work as done. So the very first part is work as done, the way work is planned, organised and done. And the last bit, policies and procedures on their own are not systems of work, that's work as imagined. So this is an expanded version of the work as imagined and work as done, and there's a few things that are really interesting about this. One is that all the bits around the outside, the different windows on how work gets done, they're all smaller than the real thing in the middle. So invariably, what really happens, we as the regulator are never going to know. So, you know, we'll look at your work through the purple one on the left and a bit of the yellow one on the right and some of those other circles around the outside. If you're in an OHS role in a healthcare service, you'll be doing the same thing. You won't see the whole bit in the middle. So I'm not suggesting that you need to see the whole bit in the middle. I'm suggesting it's good to be aware of that when we're looking at systems of work. Perdita. Okay.
We're going to beautifully, seamlessly go between the two of us. I'm a little bit shorter than Tony, so hopefully I can see all of you. I needed a stool. Thank you, everyone. So as mentioned, I'm Perdita. I am the Senior Manager of our new Integrated Industry Pilot team, and I'm bringing together our inspectors and our prevention portfolios areas. And I really wanted to talk to you a little bit about why we've got such a focus on healthcare. I've had some recent interactions with stakeholders, and I've been asked a few times, you know, why are you doing all this work in healthcare? And we're really clear from a WorkSafe perspective. Sam opened up and spoke about what our strategy is and what we're really aiming to do. Healthcare is one of the riskiest industries that we have in Victoria. So as you can see by this graph, claims, which are the injuries that are notified to us from a work cover perspective, are increasing. So these are only what get reported to us. So there is a huge larger amount of injuries that are actually occurring in the healthcare industry that we are not aware of. And this is why WorkSafe has got such a huge focus on healthcare now and for the remainder of our 5-year strategy as well. And how are people in healthcare getting hurt? Well, it's in multiple ways. And manual handling, as you can see by this bar graph, is by far the largest. And I think for most people, that's not a surprise. Manual handling has been a long-standing issue in healthcare. What you can see here as well is that obviously mental injury is also a huge factor in the healthcare industry, which for most of you, I'm sure you're not surprised by either. But what we also want to focus our efforts on as well is some of those ones in the blue box. So I'll talk a little bit about some work that we've been doing in slip, trips and falls. So that's a nice dark blue box in the graph that you can see. But you can really see a little bit like the complex healthcare industry that we've spoken about. This is not just all healthcare workers are injured due to manual handling, or it's all mental injury injuries occurring as well. This is a really complex space to happen. So if you think about an occupational violence and aggression, or aggression or violence incident that occurs, a person is likely to have not only a mental injury from this, but there's likely to be a physical injury as well. And again, this kind of shows the complexity that we see in the healthcare industry. I'm going to start with our regulatory intent, and then I'm going to hand over beautifully to Tony. So as part of our new strategy, and really importantly on our website as well, we have a new statement of regulatory intent. And for most of us that have been working in the strategic area, this is not new to us at WorkSafe. However, what we have done recently is we've flipped this upside down. So you can see here we focus on enabling performance, motivating performance, influencing change, improving compliance, and enforcing compliance. And by flipping this over, we're really showing that where we can get out to industry significantly is in those higher levels of the upside down pyramid, I'm going to call it. And this is really driving a lot of our activities as well. So this was on our website, and I'm sure Tony's got more to add with this one. I don't know if we need the mic. Oh, cool.
Thanks, Perdita. Yep, so it's the responsive regulatory pyramid. It's actually about 20 years old. Had the great privilege of meeting its inventor some time ago, Professor John Braithwaite at RegNet in Canberra. And the notion of this, and one of the reasons we've revived it at WorkSafe, is because it is actually holistic and dynamic. So it can be sort of misunderstood or misused as a way of, categorising activity for a regulator in a sort of a reductionist kind of a way, but we're very deliberately trying to use it in its originally intended way, and the clue is in the word responsive. So with typical health services, so large organisations, at any given time, we may be operating in multiple parts of this pyramid. As Perdita mentioned, the inverting of it, tipping it upside down, is to flag our preference for education and support. So enabling performance, motivating performance, we think, and all kinds of literature shows that that's the best path to safety. We are both obliged to and empowered to, though, use those tools down at the pointier parts at the bottom. And what we're trying to do now is to get better at holistically using that and use it in a responsive way. So responding to the level of risk, the past performance of the employer, and how they're responding to current initiatives. And so in that sense, this is systems thinking in play as well. There's another one of those spaghetti diagrams. This is a stamp model, and I'll let Perdita speak to it, but I just want you to know we will come back to some of these concepts and demystify them a few slides down the track.
This is working beautifully. This is a recent activity that we've done, and it's come, I'll stand on my tippy toes again, it's come out of something that we call a strategic case review. So this is a new concept that we've got as part of the pilot team, which sometimes I talk about it and I realise it doesn't sound that revolutionary, but it's really something that we've tried to really bring in with the team, where we have inspectors going out to hospitals and they'll identify potentially multiple incidents of similar occurrences happening at multiple hospitals or in slightly different ways. And what we do is we bring together a multidisciplinary team together. So quite frequently includes one of Tony's team members, and it will include our inspectors and our strategic programs officers as well. And we look at an issue that we've got and we identify throughout that responsive regulatory approach, what are all the levers that we can use? And I'm going to use an example around hand sanitizers. So we released a safety alert around this earlier this year, and there was a newspaper article as well around this, so you might be aware of it. But basically, we had identified a number of incidents where two different kind of safety issues associated with a hand sanitizer, where patients and clients were ingesting the hand sanitizer and getting significantly ill. But we also had an aggression or violence incident where a patient actually doused a bed in a blanket with hand sanitizer and set it alight, and quite a few staff members were injured as well in that process. So what we did is we took the example of the hand sanitizer being used to create the fire, and we created a stamp, which Tony will talk a bit more about later. And as we said, we've got the different structures here, which will become more apparent as we go through the presentation. But we've really tried to map out who are all the actors in the different situations and what are all the controls and feedback mechanisms for each of them. So down the bottom, we get the work environment, and then we have project delivery management, company management, government agencies and regulators, industry associations, courts and certification bodies, and up the top we have Parliament and legislation. So obviously up the top we've got our OHS Act and regulations, and we go down a level. We have, for example, WorkSafe Victoria, we have also the Australian Commission on Quality and Safety Healthcare, we have bodies like HealthShare Victoria and Safer Care Victoria as well. And then you start to see what some of those control mechanisms are that come out. So, for example, we've got the National Hand Hygiene Initiative Guidance and Risk Assessments. We've got the TGA approval of products. We've got our safety alert, which by that stage had been published. We've also got the tender processes that sit along with HealthShare Victoria. Then we get into the company management kind of space. So then we have obviously the hospitals themselves and their controls that they have are budgets, infection control policy, for example. We get into project delivery and management and we start to see the OHS team or the infection control team. And then we start to see a few more controls that you would see at the workplace. So we've got, for example, the location of the hand sanitizer. We've got the consistency of the product. Are you choosing the more liquid form or are you choosing the gel kind of form of the hand sanitizer, for example? Where are you placing these products? And then finally, we get down to the work environment. So you can see that we get from the clinical staff, the patients, in there and the patients and the families. And we've got, for example, the product, is it stored in a medication trolley? And then we start to come back up again with what the feedback is provided up through the levels. And I'm just going to touch on a few of these. For example, hand hygiene audits, OHS incidents. As we keep going up, we start to see risk registers and OHS reports. And we keep going further up. We seeing things like notifiable incidents to WorkSafe, which is how we became aware of it. And we've got things like SAPSI clinical incidents as well. So you can see what we've done in this situation is we've taken a very small, unique situation and we've mapped it against the stamp. And from this, we've not only been able to see where we've managed to put our efforts, but now we can really clearly see where else do we need to put our efforts? Where within this complete system can we have our best bang for our buck and get out there and try and really improve the situation for all of the hospitals. Thank you.
Very nice. Thanks, Perdita. So system theoretic analysis or accident? Systems theoretic and accident model and processes, analysis method and processes, one of those two. So you might notice something, the similarity between this and some of Ken's diagrams, and the levels of the system are based on Rasmussen's risk management framework. So Rasmussen, a Danish nuclear engineer, came up with a range of fantastic human factors methods. STAMP, developed by Nancy Levison, a systems engineer in the US, is based on it. AxiMap is based on it as well. But Perdita's touched on it. You can see in the different colours, different what we call levels of the system, starting from government, going through regulatory bodies like ourselves, senior company management, including boards and executives, middle management, the operational level, and then at the bottom, equipment and environment. So both STAMP uses that hierarchy and AxiMap uses that hierarchy. So I'm going to whip through a few ways that we have applied practically some of this thinking. Fires, patient handling, incident, review of systems. I'm going to guess you've got to have an acronym, and FIRES is something like that. Designed before I came to WorkSafe, so 6 or 7 years ago, in collaboration with a range of health service providers to use that AxiMap approach to model manual handling injuries among nursing staff. And what you can see on the left there, it's basically a questionnaire where people fill out a series of questions that are based on the different levels of the system and controls that were present or absent, working or not working at those different levels of the system. And that's translated into what you see on the right, an AxiMap. And the coloration of those factors is to represent linked things and themes that emerge from the analysis. STIR, I will briefly start this video. I won't play it all because it's way too long, but I'll play it long enough to give you a flavour, and then I'll tell you what it is.
STIR, the Systems Thinking Incident Review, is an incident investigation toolkit. Workplace injuries present a significant burden on individuals, employers, community and society. The factors contributing to worker injuries are complex and multifaceted. To prevent the occurrence of future injuries in the workplace, it's essential that the tools used to investigate injuries are underpinned by an evidence base that will optimise learnings. During an incident investigation, the model you choose will direct you to look at certain things and not at others. The "what you look for is what you find" principle describes this phenomenon. Essentially, the accident model you choose will determine what factors will be seen as the causes and what other factors are ignored. This means it is crucial that you choose the right type of model. The kind of accident causation model that you choose will determine the type of data collected and the method used to analyse the data. This is important as the outcome of the data analysis will ultimately inform the recommendations that will be proposed. This thinking extends the "what you look for is what you find" principle to what you find is what you fix. There are 3 types of models: simple linear models, complex linear models, and systems thinking models.
Okay, I might leave that there as a teaser and encourage you, if you're interested, to just do a search on YouTube for that title, Introduction to STIR. Unfortunately, unlike the other resources I'm going to share, this video for some reason is not on WorkSafe's website at the moment, but check it out on YouTube if you like. So another initiative we've been rolling out over the past few years is this, LEAP, the Large Employer Assessment Process. This is a way of us applying that Rasmussen's framework and those systems thinking insights to our compliance inspections of large, complex employers. And so there's a range of industries, including the healthcare sector, where we had this sort of Groundhog Day experience over multiple years of responding to incidents and going in and issuing improvement notices at the local level, at the lower part of the system, as we would say, and that would just keep on repeating. So LEAP is intended to get around that by identifying contributing factors to incidents at the higher levels of the system. And really quickly, you can see there those bottom 4 layers of Rasmussen's framework. For each of those, we've developed a range of categories, and those are categories of things that should be addressed at those levels of the system. And for each category, there's a bunch of criteria that allows either our inspectors to go and make assessments, or indeed of employers and people working for those employers to do their own self-assessment of their systems of work. Once we do that, so if it's our inspectors doing it, they'll conduct their inspections, and hopefully they'll be able to have chats with people at all of those levels of the system. They will make their observations, they'll conduct inquiries, basically conversations. They may request some documentation, which they'll take away and analyse, to make determinations about whether the risk controls have been developed. So has it been thought about? Do we have the work as imagined part in place? Whether they're implemented, so has that translated into work as done, to what extent? And is it working? Is it functional? Is it keeping people as safe as reasonably practicable? And on the basis of that analysis by our inspectors, we determine whether we think there's a non-compliance with the OHS Act, whether there's an opportunity to improve, in which case we've had a lot of success in collaborating with various large duty holders to create action plans. So that's in what Perdita nicely calls the top part of our inverted pyramid, and we collaborate with them over time to look at the enactment of those action plans. And we also, as part of the LEAP, we identify strengths of systems of work to try to reinforce what we think is good safety practice. STAR, there's another acronym for you, Systems Thinking, Analysis and Recommendations. The R part is a bit controversial. Some people don't like recommendations and call it report or review, but STAR will do. Again, you see those 6 levels. And by the way, in the use of these methods, and you saw it with Ken had the inverted version of an AXIMAP. People might know about the London Protocol, which is a similar kind of framework. It's very flexible, and very often in healthcare and other service provider organisations, the operational level gets split into 2 levels. So it might be a consumer level and a worker level, and it really depends on how you want to use it. But STAR is a collaborative thing. We're on our 4th one of those now. And what that does is uses the Rasmussen's framework to do several things. And it's the full sort of range of Rasmussen's work in creating AXIMAPs, plus a modification called PreventiMap. So what Rasmussen said was, if you just do AXIMAP analyses of a bunch of incidents of the same kind, you can look at all of those and go, what are the common contributing factors that are appearing again and again? We pull those out and we create what's called a generic AXIMAP. And then you can go, okay, for each of those generic factors, what people can have an influence on that thing? And out of that, you create an actor map. So who are the actors that can make a difference? So what we do with that is we say, okay, here's a generic AXIMAP. All you actor people, we're going to invite you to come to a series of workshops, interviews, surveys sometimes, to actually look at this system, to have a look at this AXIMAP and to refine a generic AXIMAP until that group of people who work in the system agree that this is the whole set of generic contributing factors to that kind of harm. That's the first half. The second half is through workshops and interviews and focus groups and those sorts of things. We create PreventiMaps, which, as the name suggests, is looking at that AXIMAP and saying, what do we think can be done by people at different parts of the system to reduce the causal impact of any or all or some of those contributing factors. So that's STAR. And this is one for you.
Just to follow on from the STAR, so the STAR into manual handling and mental injuries in healthcare is on our website, and if you haven't had an opportunity to look at it, I highly recommend that you do. It's really insightful in the industry, and as part of the health team, we've gone back to that multiple times during the year. I think I've read it more times than I'd ever think I'd read that document, but it is a fantastic one, and everything Tony's spoken to, you can really see that played out very nicely in the report. So very quickly, I'll talk about we've got currently a slip, trips and falls strategic visit program in healthcare. So again, most of you will probably be aware that slip, trips and falls do occur in healthcare relatively frequently. And as part of our strategic visit program, we wanted to focus on this. But with our new integrated team and with the support of our senior ergonomists who helped develop this and really led the way with the workshop that I'll talk about in a sec, we've got a program that has utilised systems thinking to identify what are those main factors that we want to focus on during the visits? Because again, we have limited time in a hospital. We're not going to solve every single problem in a hospital during one visit. So how can we really be smart with our time? So with our senior ergonomists, we facilitated a workshop with external stakeholders, so OHS directors and managers from various hospitals, and we also held an internal workshop with inspectors who had been to multiple visits associated with slip, trips and falls. And through the amazing analytical tools that we've heard so much about over the last few days, they created an Axiom map and really, again, brought things together to kind of go, what are these generic items that we want to look at? And whilst we analysed that, we identified where are the main areas that we need to go and what do we need to discuss. So there's lots of factors. Again, we can't do everything all at once, but how can we really hone in on those aspects that are consistently coming up and are grouping really nicely together? And through this, we developed our hospital visits, and we call these a problem-centric approach. So very much Malcolm Sparrow's language from a regulatory response point of view. And the focus that we've had is around interacting with equipment and also looking at external grounds as well. And something that we did that we haven't frequently done in hospitals, that we communicated to all the hospitals that we were going to be coming out and doing these visits. And through this process, we've really engaged with the hospitals, and it's nearly finished this visit project. So it'll be really exciting to do the evaluation, go back to our external stakeholders and share the learnings with them and find what we can learn and reiterate this process better again. Very quickly, this is with me as well. 5 minutes, good. We've tried to kind of show our findings generically from our visits in a way that links to Rasmussen's framework as well to some extent. And what we really wanted to say is that WorkSafe, we receive notifiable incidents, and there is legislation around it, what is notifiable. So it's certain injury types that cause a certain level of harm that are mandatory to report into WorkSafe. We also have health and safety concerns. So this is where employees or anybody with an organisation may call us and go, I've got a concern with this area. I've utilised my, for example, internal issue resolution processes. However, we're not getting the outcomes that I think that we need to be doing. And so we also will get calls in relation to that. And you can see that our common reasons that we're going to workplaces, again, probably not a lot of surprises, work-related violence, slips, trips and falls, electrical safety, that might be a bit more of a surprise, dangerous goods and hazardous substances, so chemicals in the workplaces. And I think it's really important to note that I spoke earlier about the fact that manual handling is the main injury type that we see in healthcare, but you can see here it's missing from the main reasons why we're going into hospitals. And that's a lot to do with associations with notifiable incident requirements. So manual handling injuries due to the legislation will generally not meet the requirement of notifiable incidents. However, we do see them coming up in our health and safety concerns. And this is why we strategically focus on manual handling more frequently than we do other topics as well. So when we looked at all of the reasons why we're going into workplaces, we actually found that there's real consistency, again to Tony's point with the STAR, real consistencies of what we're finding. So no matter what the topic, it really broke down into 4 things. We found that systems are either in place, but they're not implemented consistently. So work as imagined is not work as done. And we also identified that staffing shortages as well of permanent staff can reduce the effectiveness of risk controls. Incident investigation, again, is a common issue with all of these topics. So it's not consistently completed, and that people through the wristband system potentially are not inadequately supported to investigate those incidents and identify those contributing factors. And Tony spoke a bit about the STAR program that we have available as well that can support with that incident investigation. Information, instruction and training is also a key issue with all of the topics that we are doing workplace visits around. And something that's probably become a real emerging issue and is a focus that we currently have, and there will be more in this space, is safe design. So again, honestly, no matter the topic they're going into, we are finding contributing factors that are associated with safe design. So this is the new focus that we're working on at this point in time, which is really exciting.
Thank you, Perdita. So in a couple of minutes left, I'm going to zoom back out. And one of the questions I was asked to address in coming here today was, what are the commonalities between patient safety or consumer safety and worker safety in hospitals? And this little axis map that we whipped up illustrates what some of the commonalities might be, not in any specific way, but just by pointing out that there are factors in the system, that socio-technical system that consists of people, technologies and processes that are common to both patient safety and worker safety, or the lack of it. So what I would suggest is some of those conceptual things at the start, that understanding, that paradigm, how do we view the world, is fundamental. So it's fundamental to understanding and potentially changing how we approach things in terms of safety. So I might, if you don't mind, just whip through these because we've got 1 minute left. So here's a couple of case studies that Perdita and her team have been looking at that are applying that kind of idea and identifying common factors in relation to both consumers and staff. And often it'll be the same incident. So a manual handling incident, for example, a bariatric person having a fall in a room, 1 or 2 or 3 staff are involved. There's several people at risk or being harmed in that scenario. And many of the factors contributing to that are identical. But what we tend to have are separate systems for reporting and learning from those incidents. We conceptualise it differently. So that reductionism is at play in a lot of those factors that are at the higher levels of the system. Coming right back to the start and to Ken's stuff about what's a socio-technical system, if you're a person with obligations like an employer or a designer of systems, and you've got people, technologies and processes, which is the bit that you can make change to that's going to have the most lasting effect? It's going to be the technology part and the process part to the extent that you can influence it. So we know there's human variability, human capabilities and limitations vary widely. No one of us does the same thing the same way 100% of the time. So if there's a system of work that relies on a person or people doing the same thing the same way 100% of the time, it's going to fail. We know that for sure. And I would want to suggest to you that risk assessment and communication is another one of those things. We can talk about EMR and all the various whiteboards and bits of papers and all those things that are supposed to assess, manage and communicate risk in a hospital, where they fail often, and they fail often not because of the people using them, but because of the design of the system. Those would be suggestions from me for things to focus on. And that's right at the end.
Excellent. Thank you, Tony and Perdita, for that excellent presentation.